Let's get started. Welcome, everybody. Um, my name's Michael Fine. Uh, I'm a writer and community organizer, a family doctor, a public health guy, and president and board chair of Primary Care for All Americans. Thanks for joining us. We've had people from 40 states in the District of Columbia and 322 different zip codes who are working together to build this movement together. Let me tell you, the crisis in primary care is real. I have been at most of the tables around the country, and I know better most of the health policy tables around the country. And I think I know as well as anyone that there's actually no one in charge, that the cavalry isn't coming, and there's no one to fix it but us. I'm really thrilled tonight that we're going to hear tonight from Renee Chrichlow, MD, who's a real national leader in the family medicine community and community health center movements in the United States. I had the great honor of knowing Jack Geiger, the co-founder of the community health center movement in the United States, who would be incredibly proud to see Renee here tonight working on the things that she's working on. As you'll hear, community health centers are the key to our strategy of providing primary care to everyone in the United States. Please stay on at the end while our board joins Renee for questions and discussion. We'll be talking about how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for this evening, Fatima Khan, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom, to thank Renee Critchlow and all the presenters, and to thank John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Fatima.
Hi, everyone. I'm Fatima. I'm a family medicine resident at Jamaica Hospital Medical Center in Jamaica, Queens, New York, and I want to thank you all for coming tonight. Being here makes you part of building this movement as we break this stranglehold to provide healthcare to people not for profit in every neighborhood and community, primary care for all Americans. Please take a second and write where you're from in the chat. That way, everyone can see who we all are as we work together to build this movement. As Michael mentioned, we've heard you. At our last meeting, we implemented our new policy on culture, tolerance, and respect as we work together to create a welcoming environment where everyone can contribute their unique talents and ideas equally. So, no professional titles, please. Let's talk about the importance of being here together, engaged in this work, and the value of those ideas and commitments, which are what will build this movement at the end of the day. Tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them into the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speaker. Now, I have the pleasure of introducing Sherry Ayala from Madisonville, Tennessee, who is going to tell us about working with Barbara Levin, a truly great family and public health doctor who has been in Madisonville for 50 years. Hi, Sherry. Can you tell us
Hi.
where you've lived and share your experience with Dr. Levin in
Yeah.
Madisonville?
Hi, Sherry. Yeah, you can just turn your phone. For some reason, it's kicked you sideways. Yeah, that looks good. There you go. Right like that.
Okay. I don't know what's going on with it, but anyways, okay, I'm Sherry Ayala. I've lived I was born and raised part of my life in Hawaii and then moved to California. And I'm a military brat, so my dad retired out of Camp Pendleton, and I moved to Tennessee with my children because it's way cheaper than Hawaii or California. And, I didn't have health care. And so I started and I met Dr. Levin at the a woman's pregnancy center down in Madisonville. And ever since then, I've just been with her. She's saved my life. And, I hold her just so highly. I think, this marketplace or trying to get people, you know, like maybe putting flyers up around the county, trying to get them. And if they can't, you know, some, you know, are illiterate, and there should be somebody maybe inside the office at that time to help them try to get on, you know, some type of marketplace to, you know, help the doctor, you know, not, it's not free, but it's not, you know, they're not going to get paid a lot, but still it's something. Um, but you know, there's a lot of people that don't know about that kind of stuff and don't have access to the internet or computers, you know, because they live up in the mountains and there is no internet. So that's why I had to come to my son's house, because they said we lived out in the boonies. Well, I call them the boonies, but they call them the hills, but I really don't. But they don't offer internet. So I have to come over here to do most of my stuff. But, you know, other than that, you know, I'm just thankful for Dr. Levin, and thankful that you guys, you know, she thought of me to be on this website to meet all of you wonderful doctors. Yeah.
Thank you,
So
Sherry.
you're welcome.
So thank you for sharing your thoughts and experience. These are the stories that are part of our reality that we want to hear from every neighborhood and community in the United States. Now, I'm very pleased to introduce our keynote speaker, Renee Chrichlow, is an accomplished family medicine physician and health policy leader with 20 plus years of experience driving change in underserved communities. Currently, Dr. Chrichlow is the Chief Medical Officer at Codman Square Health Center, Vice Chair for Health Equity at BU Department of Family Medicine, Medical Editor for Diversity, Inclusion, and Equity at the American Family Physician, and President of the Society of Teachers of Family Medicine. Dr. Chrichlow is focused on expanding healthcare access and addressing health equity. She's a noted health policy and health equity expert in artificial intelligence. Thank you for joining us, Renee.
Beautiful.
Thank you so much for having me. I really appreciate it. I'm going to get the slides set up and we'll get going. I really appreciate the opportunity to speak with you guys, and I really appreciate the work that you're doing. Let's get this set up. You'd think during pandemic we'd have this down, but here we go. All right. And share screen. Here we go. Let me know. Give me a thumbs up if you can see that. All right, great. And let's go. So I'm here today to talk about community health centers. And I think one of the things that I think is so profound about community health centers is how deeply tied to the history of our country the development of community health centers is. And I try to make this a very visual engagement, and I want you guys to think of your questions, but I want to sort of ground you in what the community health center movement came out of. And a lot of the things that you're going to see, I live and work in Boston now. I'm Chief Medical Officer at Codman Square Health Center, and we are in Dorchester, Mass. And community health centers came out of the time in the late 60s where there was amazing civil unrest and civil change. And one of the reasons it became possible was because in this time of chaos, leaders they responded to the cries from the people. We had amazing leaders, but they didn't do this by themselves. They were responding to the work and demands of the people. And President Johnson, who came into the presidency just after JFK's assassination, wanted to make changes. And this is a man who grew up in very poor environments in Texas, serving folks there, seeing the impact of poverty impacted him in ways that allowed him to understand when people were crying out for help that there needed to be a path forward. Big civil unrest, incredible civil rights, African Americans, gays, women, everyone at this time was demanding to move forward. And the level of poverty and the disparities that we had at that time were crystal clear. It was a time during the Vietnam War and during the civil rights, basically it's revolutionary times is the best way to think about it. And in revolutionary times, chaotic times like this, people needed a path forward. LBJ was, and I want to be really clear, I think he was key in this, but he was responding to the demands of the people and the actions of the people. And that's one of the things I want to be crystal clear about. Became his presidency, 1964, his election, landslide victory. That's a very important part of what happened, is he had the demonstrated political will and necessity to make change. And with that will and understanding the necessity, they were able to make massive amounts of change during very chaotic times. You may be noticing some resonance with our current times. So I just want you to be really clear that it is in, what is it, the Littlefinger in Game of Thrones, chaos is a ladder. It's important to understand that when things are in these spaces, leaders are looking for a direction to go, and often they need the people to show them what the direction is. In signing the multiple acts around the Great Society plans, they were able to, sorry. I do love that they called it the Great Society. Because what we're looking for is like we don't need a great leader. We need a great society. And understanding that it's really clear that if the answer is money, the problem is poverty. And addressing poverty was a critical thing to do. In the Great Society, big components of it. Massive bills that were passed initially in 65 and 66. It was really important that Johnson had the political power in order to move through Congress the needed changes. He basically had demonstrated that he had a mandate. And with that mandate, he moved things through. Legislation passed with bipartisan support. And it was, like I said, one of the few things that people could agree on was we needed to make things better for all of us. And if we make things better for the least of us, it shifts society for all of us. So huge public support, massive bipartisan interaction as a result of understanding that if we were going to move forward, we had to use the levers of government to address these problems. And this is just, like I said, he came out with a mandate, and with that kind of mandate, you can make massive amounts of change. Or you can sit on your hands and do nothing. They chose to make the change because people kept pushing them. I will have you note there wasn't a great amount of diversity in these leaders that were here. But if you looked in the streets at the time, the people in the streets were far more diverse than the leaders in the buildings. Big programs in health and welfare, education, war on poverty, consumer and environmental protection. So many of the things that happened during this time were instrumental in creating and stabilizing both our economy, our healthcare system, and the fact that, if you like breathing clean air, if you like the fact that people had their education and housing, Head Start, all of these things started at this time. So with that mood, what you're seeing is a perfect time for us to say, hey, everyone deserves health. How are we going to deliver it? And when we do things on a public level, a population scale, we have the ability to impact not just infectious disease, chronic disease, illnesses, the chronic care, preventative care. The biggest things that are important to understand about community health centers is the focus is establishing at the center that the patient and the family and the communities are our priority. It's, you know, I love the hospitals. I work in the hospitals. I teach in the hospitals. But if you focus on the patient and the community, you can prevent someone from needing the hospital. If you can focus on the patient, the family, and the community, you can focus on wellness care as opposed to just illness care. If you focus on the patient in the community at every level and life part of their life cycle, you provide them a path so that they can fulfill their actual potential. Fighting poverty with healthcare is one of the ways that a lot of people were approaching this. And at this time, the early, and this is one of my favorite discussions to get into with people. I live in the Northeast. I live in Boston now. So if you talk about the community health centers, they're always like, well, the first ones were in Boston. If you talk anywhere, you know, west of the Mississippi, they're all, the first one was in Mound Bayou, Mississippi. Yeah, I don't care where the first ones were. It was important that they happened, and they did happen. And they were originally called neighborhood health centers. And they were a part of fighting poverty. If you can keep people healthy, they can keep their families secure. It is one of the major cornerstones in allowing people to fulfill their capacity. The Delta Health Center in Mounds Bayou was a perfect example of people in the community being the staff, the doctors, the nurses, the front desk, and approaching things not just as the patient had to come to them, they went into the communities. Visiting nurses were a huge thing that developed during the community health center's birth. The fact that in order to have people participate, you had to employ them. So it was, and was one of the nice, this is Bob Geiger. I believe, Michael, you knew him. I only know him by reputation. And I got to tell you, that one of the biggest things that he did was when he was educated in medical school and residency, he was curious. And one of the places he went was South Africa, of all places. He went to South Africa and he worked in an environment that was what he based community health centers on, an environment that holistically approached health by food, by employment, by community participation. And he saw this in action in South Africa and said, this is what we need to do. And with the Great Society funds, with the Great Society innovations and funding that was available, he said, let's bring this kind of atmosphere into the American system. Let's fight poverty with healthcare. Let's create an economic engine in the neighborhoods, and let's keep people healthy and families together and communities together. The Geiger Gistin Community Health Center in Columbia Point in Boston, renamed after Bob Geiger and Gistin, and still stands today as an example of the work that people do in community health. I'm almost done. So in Massachusetts alone, 52 community health centers, big fundamentals community health centers, located in designated medically underserved area, must be a nonprofit, provide comprehensive primary care and referrals to other cares, and holistic case management, community health workers. Governing board of the organization must be a majority of patients from the health center. That is key. Provide services in all areas regardless of ability to pay, and offer sliding scale. These are the pillars of the FQHC movement. And it has the impacts that we're looking for. It is lower cost. It gets to more people. And it manages all the conditions. At Codman Square Health Center, we have dental, we have eye care, we have behavioral health integrated into our primary care services. We have urgent care. We started out as the basement of a public library, and now, almost 50 years later, we are a key part of our neighborhood. In fact, during the COVID pandemic, we, working with Boston Medical Center, set up in our neighborhood and provided 30,000 vaccinations in very at-risk populations. And they were able to get those shots because they trusted us, and we created the space where they could be cared for in a safe manner. We've expanded from the basement. We're now pretty much a half a block of our building. Half of the block is our building. We have a school that's actually in our clinic, a public charter high school. Actually, we have a K through 12, K through 8's across the street, and the high school's in the building with the community health center. And we have interns from the high school that work with us and get paid. We have Daily Table, which is a grocery store that we helped bring into our neighborhood, and we work with, and especially through our nutrition, brings healthy food into the neighborhood at lower cost. We have a fitness center where our doctors actually write prescriptions for people to have lifelong fitness available in their neighborhood. We are integrated in all the ways. Our patients are seen for multiple chronic issues, prevention issues, and healthy issues. We take care of you before you're born, and we take care of your family even after you're gone, and everything in between. We're trying to live up to what Bob Geiger thought as the holistic approach to community health. We're in the community, of the community, and for the community. And that's just something that I believe in. So that's the quick run through of community health center and CHCs, and open to conversations and ready to stop sharing. So.
Well, thank you so much, Renee. That's really, I mean, amazing and inspiring to see how communities really come together. If you have a question for Renee, please post it in the chat. We will get to them in just a few minutes. But before then, Dr. Fine, or Fatima, sorry.
Our last breakout group meeting was incredibly encouraging. We had 8 active work group conversations all happening at once. All volunteers from many different communities working together to bring primary care to everyone in the United States. This moment starts with people like each one of you on here tonight. By joining and learning how communities can provide primary care to everyone and bringing one new person or more each week, we'll build this moment together. Our work groups still need more people to roll up their sleeves and be a part of the work we are doing. Please click the volunteer button in the Contact Us section of our website to tell us how you can help. Together, we can make sure that everyone in the United States receives equal health care and gets equal health, regardless of where you live, how much you earn, what community you come from, or what you look like.
Thank you so much. All right. Are you guys ready for some questions? Are we ready to go? I don't see any in the chat yet, but I have a few that I would love to ask you if that's all right. My role in my community is to be a network person. So we work actually closely with our local health groups a lot. It's one of our pillars of focus. So you know, our goal is to make sure everyone in every American neighborhood and community has and uses robust primary care. Are there enough CHC clinicians to take care of the population that does not have primary care now? And if not, how do we help find those people?
So this is the thing. This is a great question. This is how we have to fix it. We actually have to approach this in many different. If you're trying to pick something up off a table and you use one finger, you're just going to move it around, and it's not going to get anywhere. But if you want to actually pick it up, you have to use 3 fingers and you push against the table. So it's what are the multi-prongs approaches that we need to do in order to improve primary care in this country? We need workforce, we need payment reform, and we need practice redesign. And if you talk about workforce, it's the full pipeline. So pipeline, payment reform, and practice redesign. If we can aggressively attack this at multiple levels, we can have far more primary care physicians. We can have far more access. And if we do payment reform in a way, whether it's a single payer or a single payer for primary care, if we do prospective payments per member per month, based around value and quality, we can create practices that can serve far more people with even the number of physicians that we have right now. Team-based care is really the key, but we need to have, in order to have team-based care, we need prospective payments, and whether that's through a single payer or a multi-payer with a single fund, don't care. We need to have primary care funded outside of fee-for-service. If we do that, we'll be able to redesign our practices so that we can take care of the people we have with the physicians we have and the teams we have right now, but also grow that workforce. And we can do that, but we can't do it in the same system that made the problems we have today. If we change the funding, we change the leadership so that they understand, if you want to make primary care doctors, you better be making family medicine doctors, because internal medicine, for the most part, goes into subspecialty. Even pediatrics is like 80% subspecialty. You got to fund the people that are making primary care doctors and create a different kind of system to educate them so that they're always working with the patients and the communities. This can be done.
That sounds very promising. So you talked about leadership, and another question that I had is, how do we get more community folks? Like, I'm not medically trained, but I'm very focused on this idea of getting everyone a primary care. And how do I, join a board or, help to really promote CHC primary care involvement from a board level to help guide that?
Yeah. So number one, if you are in a neighborhood and are in a CHC, if you're seen in a CHC, get on the board. If you are looking to support CHCs, you need to be talking to your legislatures about Medicaid. You need to be talking to them about the fact that if they want to support people, they need to pay for the full level of care. At Codman, we have about 45% of our patients are Medicaid and 9% of our patients are in Medicare. And honestly, I'm not lobbying. What I am is educating. And I will educate you in the fact that if Medicaid paid more, then we could serve more people better, because we would have the ability. One of the biggest things we run into is staff turnover. As we have a lot of folks that come in initially lower experience, and we train them up. And as soon as they're trained up, they can get paid more elsewhere. Our staff turnover is one of the largest issues we have, and that is challenging. What did the government do? The government's done a pretty good job in doing things like, a loan repayment. I don't have huge turnover with my providers. If I have a provider, they generally stay with them. But it's getting people in the door with competitive salaries and, providing them an environment that allows them to do the care that they want to do, is serve the patient, not be a hamster wheel, widget producer. So yeah, you want to help us? Payment reform is one of the biggest things that can be done. Find better ways to pay for healthcare.
Yeah. I see Scott's raised his hand. Scott, did you want to come off mute and ask a question directly?
Yeah, I would really appreciate that. Could you help me understand the governance? So, we work with a lot of medical groups across the United States, and we take data and we help empower teams to take better care of people. But when I go to FQHCs, they're like, no, we don't want to do that. We don't get paid for that. That's not the incentives that we have. We get government funding from other sources. And I'm like, well, what about, the comprehensive data and being more proactive and proactive outreach? Well, we've got our gaps in care closure program. We've got our
Scott, this is a problem. Everyone, how they say, you don't want to serve two masters. Well, you don't want to serve any masters, but I'll tell you what, this is what's going on in healthcare, is that we are held to account about are held to account for visits, visit volume. The way things are paid is all around visit volume. And we don't have enough staff. And so one more thing that's added to our plate, all of our operational staff, all our front desk staff, everyone's doing like 15 things. And where we run into challenges is that making the transformations that would make it easier, we don't even have the people that are able to take the time to make the transformations to make it easier. We need upfront payments in order to just make that switch over. And that's where the big challenge is. Bandwidth alone is a huge problem. Every single operations person I have is doing 2 operations person's job. And it can get better if we had the ability to transform our practices with data and all the things that are wonderful. But the fact is, we don't have the ability to make the changes because we're stuck on the hamster wheel. And that's what we're beholden to right now. So if we can stop the hamster wheel, practice redesign, we're set up for it. Love to have it. But the hamster
Where
wheel
does that
is
happen?
that
Where does it happen? At what level of government?
Okay, so this is the thing. One of the cool things that's happening in Massachusetts is we have 1115 waiver for our Medicaid, and we are on prospective payment for that. But it's not quite covering the cost of care. It needs to be it needs to be a lot more in order to create the space for us to do the big practice changes that need to happen. And honestly, this is one of the things that one organization I've seen has done. I wish I could remember the name, but what they've done is they basically, we have this huge practice transforming thing, and we're going to give it to you free for 2 years, and we're going to give you support to institute it. And that is actually something that's going to happen because people are like, okay, well, they're going to give it to us for free for 2 years, and they're going to actually give us the support to make the transition that gives us bandwidth and capacity. We can make that change. So those are the kinds of things that need to happen. If you proactively can invest in these CHCs, if you can give them the time and space and the support to make the changes, if you want to make a change, you better be putting someone in the building that's going to help work with them to make a difference. Because right now they're on a hamster wheel, and the master that they're serving is fee for service and visit volume.
God, if I can jump in for a second, the really only way to make this happen is to build a social movement, so that,
Yep.
And as
Big time.
Renee pointed out, and pointed out brilliantly, so that the politicians have to do what their communities need for once, instead of doing what people with something to sell pay them to do. We can change that, but only if we organize ourselves.
I think that is exactly what we are here to do, Dr. Fine. There are so many more questions if you look in the chat, and I know some people still have their hands raised right now. We will come back in just a minute, but we know this is about building a movement. We know that there's so much work to be done. Thank you so much, Renee, for your time. We hope that you'll stay on just for a little bit after we tell people a little bit about what's coming next. So that we can continue to have these conversations around these great topics. But Dr. Fine, do you want to tell people a little bit about what's going on?
Sure, though I think I'm Michael Fine, just to remind everybody.
Yes.
We're trying to make that change as we're trying to make many other changes. And the changes we're trying to make are exactly what Renee told us to do. We're trying to work not with one finger, but with all the fingers of all of our hands, doing many things at once. We're trying to build work groups in 25 neighborhoods and communities. We're building work groups focused on exploding the number of health professionals we're training, state by state. We're building work groups to improve how Medicare and Medicaid support training more primary care clinicians and paying them intelligently so we can provide primary care to all Americans. We're building work groups to stand shoulder to shoulder with students from our communities, that pipeline that Renee talked about, and to remove the burdens and the roadblocks so students from all our communities are free to learn and free to come back home and free to care for the people who cared for them and pay it forward. Movement building is this crazy, huge undertaking. It's nuts. But the problem is, if we don't do it, it's never going to happen. And remember that the folks with something to sell, who are taking something like $2.5 trillion out of our communities, aren't going away because we just say pretty please, but they will go away if we outsmart them and outrun them, which means building a healthcare system for everyone from the ground up, community by community, remembering the work of Dr. Geiger and Count Gibson and others, who did years ago to build on that work and make it so that we have community health centers or something like community health centers for all Americans. Healthcare impacts all of us. When we work together, on the other hand, there's nothing we can't do. So please, let's reach out to colleagues, family, and friends. And remember, this isn't a Republican thing. This isn't a Democratic thing. This is an American thing. Remember that the cost of healthcare affects all of us. We're the public in public health. The only people to do it is us, and the only time to do it is now.
Thank you. In 2 weeks, we will meet again and break into work groups. We encourage everyone to find someone new to get involved in this impactful movement to our next Zoom meeting on May 28th. Register on our website, primarycareforallamericans.org. And while you're there, click volunteer in the Contact Us section of the website and tell us how you'd like to be an active part of our movement. And please click donate to support our work together with a contribution. Every little bit helps. We need and appreciate every single one of you for helping to spread this movement across our nation in order to get the change we need and you deserve. Healthcare for people, not for profit. Primary care for all Americans. Please take a minute to complete our survey. The link is in the chat. We want to hear from you. If you would like to talk with members of the leadership team, stay on our call, and board members of Primary Care for All Americans will stay on to hear your feedback to help us grow as a community. Thank you, everyone. See you on May 28th.
Thank you all. Any questions? Why don't we have people raise their hands? And Patty, if you can moderate and call on people, we should be able to move through this pretty easily.
All right, let's hop in and see where we are at. All right, so Elena, you had your hand raised earlier. You have a question.
Me?
Yeah.
Eliana? Yeah.
Ariana, sorry.
That's okay. I just wanted to make sure actually you meant me.
Yeah, yes.
I'm just curious, Dr. Chrichlow, I'm sorry, I don't know how to say your name. How long did it take? I mean, I'm really impressed. I was in the tenant rights movement and we had housing programs and boy, it was batting your head against the concrete wall. And I'm just curious, how long did it take to set up all these different kinds of programs for your community? And how is it structured? I mean, they have to operate independently to a certain extent, but is there an overall community development corporation or something that is like jabbing people in the back and trying to get funding for these programs, or making sure that if somebody passes on or moves away, some particular corner doesn't fall flat? So,
No, well, I appreciate your question. And yes, you did actually say my last name perfectly the first time. It is Chrichlow.
okay.
So well done. So I stand on the shoulders of giants. The Codman Square Healthcare has been in the Codman Square neighborhood in Dorchester, Massachusetts for about 47 years now. And from day one, it was formed from the community, by the community, and with people who really believed in grassroots movement. We work in partnership in order to make these things happen. We worked in partnership. The Daily Table was actually in partnership with a gentleman who founded Trader Joe's, I believe, was looking to pay it forward and address the fact that there were grocery deserts, and we worked with them to set up the Daily Table, and the first one was in Dorchester, just a couple blocks from our community health center. Now I believe they have like 6 of them in places that were previously grocery deserts. Same thing with HealthWorks, which is a gym corporation. They were looking to do the right thing somewhere. Our development folks reached out. Oh, hey, Wayne, I see you. Our folks reached out to our development folks reached out and said, hey, you want to do the right thing, come to this neighborhood, put a gym in, and we will be sending people. And the cooperation that we had was, yeah, we'll also make sure that our patients will be able to go there at a lower cost. And we have like a $10 a month membership for some of these folks. docs just write prescriptions and it goes there. So a lot of what we do is we're big connectors and augmenting the voices of the patients. So examining what our patients need, finding partnerships to collaborate with, and the biggest thing that we do is augment the voice of our patients. So that's how we sort of work through all those things.
I actually lived on the edge of Codman Square from 80 to 83 or 84 or something. So I think there actually was, it was just starting then probably.
Yeah. No,
But
those are the early days.
It's a whole long story. I wasn't connected to that kind of stuff at that time, but I just, from my tenant movement stuff, but it's a lot. And it sounds like you have some really good negotiators who.
Yeah, we have,
that's a big.
we have passionate people, and it's really about getting passionate people together and getting them right direction, and then making the people with all the money
Want to help.
A lot of folks want to help. They just don't have ideas. It's getting the people with the ideas together with the people with the money, and then augmenting the patient's voice.
Right, and keeping the patient's voice in there, because we had so much trouble in housing. There were these programs, we called it urban removal and the war on the poor, because they wanted to fix everything up to look nice, and we didn't look nice. So goodbye for you. And that was not what it was supposed to be about. And by the time it was happening, it was ridiculous. And Section 8, the amount of money you could make and be in Section 8 was, it was nice in a way, but it was so high that too much of the housing got taken by people who probably could have managed anyway. And then the people who were really dirt poor, who weren't so savvy with this kind of stuff, got left out in the cold. Anyway.
Yeah, and one of the biggest things that we're trying to do with payment reform and team-based care is being able to pay our lower wage folks enough money so they can live in the neighborhood that they serve. That is a really challenging thing. So we're trying to be as creative as possible and keep moving forward with the movement. Patty,
this is absolutely, you guys talk about passion, you talk about creativity. This is that group of people right here. Let's hop over to another question that we've had coming in. It just went down a little bit. Where was it? So I think, Brian, you had a question that had come up. Did you want to ask it? Come off mute? Or did I misread?
Yeah, that was my fault.
Okay.
Somebody in the chat asked a question of somebody else in the chat that was not.
Okay. No, that's all right. I thought I wanted to make sure I gave space for that. So, okay, let me come here. Fred Harrington had asked about streamlining a billing process. Would that work?
Oh yeah. Okay. So this is the thing. This is the thing. If we just got prospective payments for each lives that we were taking care of, each patient lives that we're taking care of, if we got prospective payment, I could get rid of my entire billing department. The goal I'm looking for is if there's money spent in the clinic, it's spent on the wages of the people that are touching the patients. We need total clinic. That's the kind of payment reform I would like. I would like every dollar that's spent there based on team-based care, patient-facing, and that we don't. Right now, I literally have one of the major expenses we have is just people who are on phones talking to insurance companies. I would rather pay a behavioral health therapist more money so they can talk to more patients. But literally, there's huge chunks of our expenses that has nothing to do with facing the patient and everything to do with facing insurance companies. Streamlining billing would be huge.
That's a great way to put it. Total clinic. We need to hop that word.
That's what I'm looking for.
About 40% of primary care overhead goes to billing, not to patient care.
Absolutely. And I believe Wayne Altman just suggested you for 2024 campaigning in the chat. So on that note, Brian looks like he actually does have a question now.
Yeah, following up on what you were just talking about, do you have a dollar number, what it would cost per patient per month or per year to meet those goals you just talked about?
To meet those goals? Yeah, we have some ideas about what we think that would look like. I would tell you, the data was, where are you, Wayne? Zuri is our data guy. Oh my God, I said Zuri and my phone thought I said Siri. So there are data, there are numbers. What we're looking at right now, if you look at the total cost of the primary care, is if it's $1 of healthcare money, primary care is getting about 5 to 6 cents of that. To make a big initial change, the first thing we do is double that. To make massive change in the way that we are actually formatting our healthcare system, I'd say we need to hit at least 20%. 20% of our healthcare dollars going to primary care, and we don't see the problems that we have. It's an investment. And like I said, I'm a big fan. Total clinic is an idea I have where literally I need to have at least 90% of the revenue that I'm bringing in goes to pay the people that are touching patients. Total clinic comes from the idea around total football, which is a soccer term from the 70s, which is awesome, but I won't get into it. So
Have you looked into that on a micro level though? What your clinic needs to bring in per patient?
yeah, we have that information, and like I said, it's part of what we're working for with a payment reform. We have currently, we receive about $700,000 a month from Medicaid, and that is for 45% of our patients. So if you look at doubling that, $1.4 million a month would allow us to do our best care for our patients. And you know what? That's just not a lot of money, but then it's not what we get.
No.
Brian, when you look
Thanks.
around the country, it looks like the number is probably close to $100 per patient per month. Renee, you may disagree with that, but I think that's pretty close. That's
No,
about
that's
12. For context, that's $1,200 per person per year. In the United States, we spend $14,000 per person per year on healthcare, and only a fraction of that, as Renee said, about 4.5% to 5% goes to primary care, which is the only medical service that's ever been shown to improve public health outcomes as it contains and reduces costs.
Yeah, and so just real briefly, someone in the chat mentioned that the prospective payment model sounds a lot like the DPC, which is what's called direct primary care. And yeah, it is. It's just scaling it to the level where it can be for everybody. Per member per month, prospective payment allows teams-based care, allows integrated care. It's allows us to spend money on patient care, not on billing.
Thanks.
Sounds great. Greg, you've raised your hand. Where are you joining us from?
Indianapolis, Indiana, and thank you all for your conversation. My question is, are community health centers just for underserved areas? Michael, if I'm not mistaken, in your book, The Nature of Health, you implied that community health centers were first designed for everybody, not just for underserved areas. And I wonder whether we had momentum in some of the, not just in the underserved areas, but at other areas also, that this could really spread over into the underserved areas also.
Yeah, no, community health centers were brought up through the federally qualified community health centers were specifically put into underserved areas so that they could impact inequities. And if you think about this, if you think about what inequity really talks about, equity is putting resources where they're needed the most. It's putting resources where they're needed the most. The coolest part about doing that is when you put resources where they're needed the most, it shifts the system for everybody. So yeah, the work that we've done in community health centers, a lot of it is an excellent way to deliver care. But what you're looking at when you're spending your federal dollars on adjusting the overall healthcare of our society, we need to put resources where they're needed the most in order to relieve that burden. Because if you have a limited amount of money, putting FQHCs everywhere, equality versus equity doesn't solve problems. Equality won't close the gap. What closes the gap is putting resources where they're needed. That brings things up. Equality won't fix these problems. Equity fixes this problem. But the good news about it is if we do that, healthcare gets better for everybody.
And on the other hand, if we go above and beyond that and
Oh, yeah, big
provide
fan.
one neighborhood health station, what we called it in the Rhode Island proposal, for every community of 10,000 people that looks exactly like Codman Square.
Oh, big fan, big fan.
If we do that for every 10,000 people, we don't by itself address health disparities. That needs that focused work of community health centers.
Yeah.
But if we provide this to everyone, we expect that our public health outcomes would massively improve across the country, and the cost of healthcare would likely drop 30 to 50%, like countries around the world that actually do this and do it well and put us to shame. And they spend 60% less than what we spend.
And that is really about, that is going beyond equity and beyond equality. What we're looking at, that's fixing the problem. Is primary care for everybody, well-funded primary care for everybody is what this country needs. And that's going to involve investment in building a higher capacity workforce for primary care. That's going to involve changing the way that we both admit people into medical school, pay for medical school, and how we do things in medical school. Yeah, no, I 100% believe that, honestly, I'm going to sound a little, just throwing it out there. I don't care if there's single payer for everybody. I would like single payer for primary care, because if we had a public option for primary care, everyone in this country would be healthier. And I'm just saying, I'm a fan, and the data backs us up.
And Dr. Geiger is grinning in heaven.
Well, it looks like there's a lot of people who are fans. So one question that's popped up is about, does Medicaid prevent the movement of funds into primary care reimbursement? And I guess one of the questions that I would ask is, in addition to that, is what are the top hurdles that you see needing to be really righted to fix this problem quickly, right? You talked about the hamster wheel, right?
Yeah, no, to fix this problem quickly, we need leadership that has some intestinal fortitude, is what I'll say. Because this is the thing. We know that primary care is the path for better healthcare. But what we don't have are government officials who are willing to step out and say, yeah, we need to make a change and we need to do it collectively, because they're afraid of being called communist. They're afraid of being called socialist. They're afraid they won't get reelected. But the fact is, if they had some intestinal fortitude, they could be able to institute the changes that are necessary. Payment reform, pipeline development, which is workforce, and practice redesign. We could fix this in 5 years. Not a problem. We need people who have the will to step up and say, let's do this now. I yell a lot, I'm sorry.
It's okay, my headphones are in, my kids can't hear you. So these are great questions. Let's see what else we have coming in. Does anyone else? I don't see anyone with their hand raised. I just want to make sure
I have one more based on what you
Okay.
just said, Renee.
Go ahead, Brian.
Are you following closely states like California and Washington that seem to have some politicians that have some fortitude that are trying to do things?
I'm not following closely. I'm in their lap.
Okay,
Literally,
good.
yeah, no, I am one of the things that I'm the
Massachusetts, sorry.
Yeah, that's okay. I'm the chair of the Commission for Federal and State Policy for the American Academy of Family Physicians, and as the immediate past president for the Society of Teachers Family Medicine. Literally, I'm going to DC on next Monday, and we meet with all these folks all the time. We are basically spreading the gospel of payment reform, and there are a few of us at our last meeting in LA. A few of us left with the idea. It's like, yeah, you know what? We're just going to do single payer for primary care at our state level, and we're going to show people that it works. So yeah, no, trust me, we're deeply involved with each other. It's a love fest, is what it is.
All right. Well, let me know if
That's-
you want to have a drink while you're in DC.
Oh, cool.
No, this is great. And, not to shameless plug for next week, where we do go into our breakout sessions. We have work groups for 5 different states that we will be breaking out into to talk about these things. We have groups about engagement. We have groups where really those of us that have the iron stomachs ready to deal with some of these issues and ready to stand up and make some noise can come together and feel supported by one another. So if you are not signed up yet, if you are not bringing friends to that, 2 weeks from tonight, May 28th, is that time to really roll up our sleeves and get to work. And it's by adding friends like Renee into our circles that we can really start to see more and more movement and get more and more direction on where to go. Dr. Fine, Michael?
Thank you. Well,
It's hard.
yeah, it takes practice. But thank you, Renee. Thank you, everyone, for being here tonight. This gives us a taste of what we can do together. This is not a difficult problem. The problem isn't intellectual. The problem is organizing. So to quote Joe Hill, don't mourn, organize. Go out and talk to other people. If you're a clinician, talk to people in exam rooms. If you're not a clinician, talk to everyone you know. Help people understand the numbers and then bring them here in 2 weeks and let's get to work together.